Welcome everyone to this webinar on prescribing challenges in youth mental health. Today I'm going to cover the context for prescribing psychotropic medication, issues to do with consent for prescription, shared decision making, and then the relational aspects of prescribing, that is the doctor-patient relationship and how it affects prescribing. This webinar will not cover prescribing in children less than 12 years of age, and it will cover neither specific disorders nor specific medications. It's well known that psychotropic medication prescription has increased in Australia and internationally, and this has aroused a great deal of controversy. You can see on this next slide that psychotropic prescription has risen overall in Australia and risen in the antidepressant, antipsychotic and stimulant or ADHD category of medications. In 15 to 24-year-olds, you can see quite marked prescribing changes even over the period 2009 to 2012, with rapid rises in some medications such as desvenlafaxine and also more gradual rises in other categories of psychotropics, particularly other antidepressants and stimulants. The fall that you can see on the screen there in venlafaxine is because desvenlafaxine has tended to replace it in primary care prescribing. In 15 to 24-year-olds, the most rapidly changing drugs have been desvenlafaxine, methylphenidate, duloxetine and quetiapine, with significant growth in prescriptions even over this short time period. What's been controversial is that Australia has one of the highest rates of antidepressant use in the world. The rate of antidepressant prescription has more than doubled since the year 2000, and despite the evidence of modest effectiveness of antidepressants, prescribing is still increasing. One of the reasons for the declining effectiveness, or so-called declining effectiveness of antidepressants, is that there's been an increase in placebo response rate. But also there's a similar problem with the psychotherapy. So it's not just that medication has been shown to be only of modest effect, but also the psychotherapy, particularly cognitive behavioural therapy, are only of modest effectiveness. The other trend is the trend toward polypharmacy. These are United States data, but it's likely that the trends are similar in Australia, that the number of people on multiple medications is also increasing. And you can see at the top of the screen there, the number who are on 2 or more medications has increased quite significantly, and worryingly, the number of people on 4 or 5 medications is also increasing. There's been a move toward guideline-based pharmacotherapy, and the aims of this are to reduce or prevent inappropriate or harmful prescribing, but these are very blunt instruments, and mostly the experience of prescribing in general, but particularly for young people, is that telling people what to do doesn't really change people's behaviours. And so we need a more subtle approach, a more nuanced approach to prescribing, and also to coping with the multiple problems that young people present with. Guidelines are usually for single disorders or syndromes and rarely cope with complexity of presentations. And the question here is not just about overprescribing, but also about underprescribing as well. Overprescribing is often emphasised, especially with regard to antidepressants and treating emergent side effects, and the second generation antipsychotics and their metabolic influences on particularly young people who are more susceptible to metabolic side effects. And we know that somatic comorbidities, including diabetes and cardiovascular disease, are key contributors to premature mortality. So it's right and proper to have concern about prescribing these medications. But what's not emphasised as much is the risk of underprescribing, especially in moderate and severe disorder, where delay in treatment can be developmentally harmful, neurocognitively, emotionally, and also psychosocially in terms of the disruption to family and social networks and vocational pathways. So what are we aiming for in prescribing? We're aiming for clinically appropriate prescribing, neither under nor over prescribing, and to be able to match the treatment to the problem at hand, and then to limit polypharmacy and iatrogenic harm, that is the harm that's done by prescribing and by the health profession. What we know is that in young people, diagnostic uncertainty is the norm in youth mental health. Young people don't read or respect the DSM. They don't come in telling us what they have, and they certainly don't conform to the descriptions in the DSM, which are really descriptions of late-stage disorder in middle-aged individuals. So Professor Patrick McGorry, my colleague and the director of Orygen, has introduced this concept of clinical staging, which is a subtyping strategy to help to select safe and effective treatment and to predict outcome. And at Orygen, we've been devoting a lot of effort to working on this staging model as a more refined method of diagnosis. And the principal benefits of this are that it will restore the utility of diagnosis and promote early intervention. And particularly it will do this by highlighting the different treatment needs according to the stage of illness, rather like cancer staging. Early stage treatment is usually simpler and benign and more effective than late stage treatment of the disorder. And the reason we need this staging model is illustrated in this slide, which shows the progression from stage 0, that is asymptomatic people, through to stage 4, which is treatment-resistant individuals. And you can see the kind of end-stage adult phenotype disorders at the bottom there, or a selection of them. But young people presenting early in the course of these disorders usually present with blends of psychopathology and mixtures of symptoms. So they present with a bit of substance use, a bit of psychosis, a bit of bipolarity, maybe some personality pathology. And they don't present with fully formed syndromes for which conventional guideline-based pharmacotherapy is going to be appropriate. So we need a more nuanced approach. We've attempted to integrate this staging model for both mood and severe personality disorder in our work at Orygen. This is a paper that was out earlier this year. And the point of this table is to show you that, for example, at stage 1A, which is mild or non-specific mood disorder or severe personality disorder, but mild symptoms of it, that mental health literacy, psychoeducation, simple interventions are often appropriate. And you'll see that medication is not introduced until around about stage 2 disorder. And so this is an attempt to match treatments and have a proportionate response to the problems that we're facing clinically. So as well as stage of disorder, we also need to think about severity and complexity of problems, severity of functional impairment, when we think about how we go about prescribing. Even with the knowledge that we have about prescribing for young people, we know that access to evidence-based treatment is poor, and that absence of evidence, that is an evidence vacuum, will lead to heterogeneity of practice and often quite marked disputes among people about how to approach a particular clinical problem. And a key problem that we face is the risk of polypharmacy, which you saw, which is on the rise in young people. And this is really to be contrasted with augmentation strategies, which are a legitimate part of the treatment of severe and unremitting disorder. The difference being that augmentation is a planned strategy, whereas polypharmacy is an unintended consequence of prescribing multiple medications. Augmentation is also an experimental approach to prescribing, whereas polypharmacy tends to be reactive to problems. And the message here, which I'll come back to, is that if a medication is ineffective, then it should be stopped and another one tried. So when medications are prescribed, they should be used in a way that maximises their effectiveness. For example, antidepressants still have an important role in the treatment of moderate to severe depression, but they need to be provided as part of an overall treatment plan that might include psychotherapy and lifestyle changes such as diet and exercise. But it's not enough to just tell somebody to do this. There are other factors that enhance the effectiveness of prescribing, and those of you who prescribe or who work with young people who are prescribed medication will know that just asking or telling somebody to do something really changes their behaviour and the outcomes. So what should we think of when we think about the other factors in prescribing? The context of prescribing is the first place to start. All prescribing needs to happen within the context of a comprehensive biopsychosocial assessment and treatment plan, an examination of the evidence base, knowledge of the evidence base, and a decision to be made is whether medication is indeed indicated for the problem that the young person presents with. The biggest problem that prescribers face is what happens when there is no evidence base, as is the case with much prescribing in youth mental health. And I will come back to some issues of how to approach that and some suggestions about how to approach the lack of evidence. All young people who take medication need to consent to the administration of medication and to the prescription of medication. And it's generally accepted that most young people over the age of 16 are capable of giving their own informed consent. And in Australian common law, those who are under the age of 16 might be considered as what's called a mature minor, whereby they can give informed consent if they have sufficient understanding and intelligence to be able to fully understand what is proposed in the treatment plan. In fact, the mature minor principle applies to all young people under the age of 18, but especially to those under the age of 16. A mature minor, or someone can be designated a mature minor, when the young person understands all aspects of the advice that they're given, where the medical professional can't persuade the young person to involve their parents in care, and unless the person receives that advice and treatment, their physical and or mental health are likely to suffer. And an important guiding principle is that the prescription of this treatment, or whatever treatment is offered, needs to serve the best interests of the patient. If you're unsure about whether a young person is capable of giving consent to their treatment, then it is always advisable to consult and or obtain a second opinion. And I would point you to the article that I've referenced at the bottom of the screen there. It's some really excellent guidance on navigating these issues. Importantly, the mature minor principle is not an excuse to ignore the wishes of parents or important others. And the word persuade is in the previous slide for deliberate reasons. That it is always important to revisit that goal of involving a young person's family or important other people in their care. And if this is not a single cross-sectional conversation, this is an ongoing dialogue about the involvement of others. And many young people will have good reason not to have others involved, but this also brings with it some hazards, such as having to conceal treatment from others, which makes adherence to treatment all the more difficult. When prescribing does occur in a young person, it's important to have a shared understanding among those involved in the young person's network, whether it be a family member or partner, the school, particularly for medications like stimulants, drug and alcohol services, vocational support services, youth workers, family support services. A whole range of people involved in the young person's network are much more involved in prescribing than they might otherwise be in prescribing for adult patients. It's also important to take the preferences of those groups into account. That doesn't mean that the school gets to dictate whether a young person has a prescription for medication, but it is important to understand strong objections from the school, from out-of-home care staff, or strong desire on the part of those people involved with the young person to have a particular medication prescribed or a particular strategy pursued. Things become particularly complicated in out-of-home care and in youth justice settings where there can be marked conflict and differences in opinion about the role of prescribing and the importance of prescribing. The setting in which prescribing occurs is also an important consideration. There are marked differences between prescribing in a primary care setting through to a specialist mental health setting, educational or justice or out-of-home care setting. And again, these are important issues to take into consideration with regard to practical issues about how realistic it is to adequately monitor and administer medication, but also the complexities of monitoring side effects, taking into account people's wishes. Then there are particular issues to take into account, such as the so-called black box warnings, which are these warnings issued by the Food and Drug Administration in the United States, and which are often reissued by other drug regulatory agencies around the world about particular warnings. And the most common one for young people is the warning about treatment-emergent suicidal ideas or behaviour and the prescription of SSRIs. And this is a problem for young people up to the age of 25. It's not just something for under 18s. There are also side effects that need to be taken into account, particularly the metabolic syndrome with the prescription of second-generation antipsychotics, and then the potential for misuse or abuse or on sale on the street of benzodiazepines, retardant stimulants, and other medications. When we prescribe medication, it's somewhat naive to believe that doctors' orders are just going to be followed. And the role of collaboration is not really emphasised a great deal in medical training, not emphasised enough in medical training, in terms of enabling the person who's receiving that prescription to be able to properly understand and join with the doctor in the decision to prescribe medication. And I'll come back to that in a short moment. There are also logistical and practical issues about the complexity of the drug regimen, frequency with which drugs are prescribed. My preference is always to prescribe once daily. If you're ever taking medication yourself, you know that a regimen more complicated than once daily is often very difficult to adhere to. And then there are health beliefs, beliefs about complementary and alternative agents, and general knowledge about prescribing and medication that are important. I'm going to talk now about an important issue in thinking about prescribing in young people, and that is how do you actually go about the decision making. This is work that my colleague Regina Simmons has carried out at Orygen and continues to undertake, and I would point you to a number of publications that she's been involved in at the bottom of the screen there. And this notion has an enormous amount of face validity, and I think when you hear about shared decision making, most people's first response is, well, I already do that. But what's interesting is that when you actually observe and rate people's actual conduct in the clinical encounter, there's not a lot of evidence that people do actually engage in genuine shared decision making with individuals. And essentially what shared decision making is about trying to bring the decisions that the young person makes after they leave your office back into the clinical encounter. You can see the timeline there that the clinician starts the consultation, they discuss, the clinician and the young person discuss medication options, and then the young person leaves with a prescription and actually only makes the decision about medication, about filling the prescription, taking the medication after they've left the clinical encounter. what shared decision making does is tries to, during clinical consultation, help the young person to integrate their preferences with the evidence and what's available and what the clinician can offer. And this is a collaborative process. This is not about disempowering clinicians. This is about empowering young people to make more active decisions in their own care. And shared decision making enables a clinician and a patient to participate jointly in making these decisions by discussing the options and their benefits and harms, considering the patient's values and preferences and circumstances. And as I've suggested, this is a process rather than a single discussion. This is something that you might visit and revisit in multiple consultations. The main benefits of shared decision making are the incorporation of evidence into the patient's preferences, improving patients' knowledge, the perception of risk, the accuracy of that, and the accuracy of patient and clinician communication, and then reducing decisional conflict or the feeling that the young person might be uninformed, and also reducing inappropriate prescribing and inappropriate ordering of tests as well, if these things are gone about in a shared way. And there are 5 key questions that we need to ask when engaging in shared decision making. The first is, what will happen if the patient waits and watches? What is the test, or what are the treatment options? What are the benefits and harms of each of these options? How do the benefits and harms weigh up for that individual patient? And does the patient have enough information to then make a choice? This is not a linear process. The deliberation over these decisions involves exploration and discussion of evidence and the patient's values and preferences. Sometimes these are not fully formed and not clearly known to the patient, and the process is what actually helps clarify them. And the selection of a treatment option should be based on both evidence and values and preferences. And there are 12 main steps that cover 3 broad areas in the process. The first is there needs to be a 2-way information exchange where perhaps evidence is imparted to the young person, but also the young person imparts their values and preferences, with the clinician being fully informed about what's important to the young person. Then there's the deliberation process, then the selection process. And these decisions can be supported by tools which are called decision aids, which I won't cover today, but which you can find if you follow up the work of Magenta Simmons, you'll find the work that she's done on decision aids. The 12 steps are on the screen there. They essentially go from identifying the problem, choosing the options and listing them, evaluating the pros and cons, through to exploring expectations and concerns and fears, and then evaluating the comprehension of that information, allowing questions, and then offering the deferment of the decision if necessary, and then arranging for a review of that decision. And the advantages of shared decision making you respect the client's rights, you clarify the decision making process, increase the likelihood that this decision making process is a positive experience, and of course the aim of this is to improve outcomes. That's our ultimate aim for our involvement with Orygen. The goals for shared decision making in mental health are genuine involvement with an explicit offer plus clarification and exploration of what this actually means. The decision is embedded within a more holistic model of care. Information that's evidence-based, relevant and personalised and meaningful is introduced into the conversation. There's an opportunity for deliberation, and the approach is flexible to caregiver involvement, the capacity of the individual to make decisions, and this is where shared decision making is sometimes confused with supported decision making. Supported decision making is for people with impaired decisional capacity. It can take into account comorbidity, information, needs and wants, the nature of the disorder and the decision, and it allows time. And of course then, as I said before, you can plan for revisiting the decision, and a decision is not irrevocable. What's required is a willingness on the part of clinicians and young people to share. It does require time, and it requires skills and knowledge about, not just about evidence that is brought to the decision, but also the evidence, also knowledge about the process of shared decision making, and it does require some resources to be able to deliver. And you can see there's components. There's a clinician contribution, a young person's contribution. They both need a belief in the benefit of sharing decision making and a willingness to participate, and an acknowledgement that current preferences are at least partially unfair. And it's a blend of activation, communication, and collaboration, which results in informed preference. Now, you might be saying that either this is too long, or too time-consuming, or that not everybody wants this. But actually, there's been a good deal of empirical research in the area of shared decision-making. And pre-systematic reviews have said that there's no systematic increase in consultation time, that there's a misinterpretation about clients being unsupported, and that the involvement and process actually leads to better support. But surveys show that young people actually want to be involved in shared decision making, and you can't assume that people don't want this. And an assumption often that people can't be involved. In fact, the behaviours can be learned. It's feasible in major depression and schizophrenia in adults, where a lot of this work has been done. But there's emerging work where this has been very effectively applied to young people. And importantly, vulnerable people are less likely to engage in shared decision making, but actually need the most support and are likely to benefit the most from shared decision making. And I alluded before to the fact that most people think they already do this, but actually 33 studies of people who thought they were doing shared decision making indicate that they're not in day-to-day practice actually doing the nuts and bolts of shared decision making. And shared decision making, in contrast to the belief that the misunderstanding that we're increasing in anxiety, in fact doesn't lead to any increase in anxiety. And anxiety is often confused for decision with conflict. This is a screenshot from an evidence summary that Orygen has published on shared decision making, which is available on our website. And I would certainly encourage you to follow that up for more information about the shared decision making process. Now, shared decision making requires an individual to know or understand the common assumptions or rules of interpersonal behaviour and relationships. Many of the difficulties that we encounter in prescribing to young people is that many young people who present with clinical problems will not engage in the common rules or assumptions about interpersonal behaviour. And so we need to think about how we can be most effective in prescribing for this group, who actually are often a more needy group in terms of mental disorders, but who often get the least effective treatment, particularly if we just blindly follow guideline-based prescribing. This group of patients will often find it very difficult to simply follow rules or your rules or even understand them. So what we suggest in this situation is taking a relational approach to general psychiatric care and prescribing. Now, this approach is actually one that is generally indicated for all prescribing, but it becomes particularly important when in this patient group you find relationships difficult to manage. You need to remember that all prescribing occurs in the context of the doctor-patient relationship, but this takes on particular significance when the individual has relational difficulties or even disorder, that is, personality difficulties and disorder. And personality difficulties are very common among young people, personality disorder occurs in up to about 14% of young people. So this is a common problem that you will face, particularly in clinical settings, where the prevalence of personality difficulties and disorder is even higher. So the interpersonal difficulties and challenges of this group of young people are particularly around maladaptive help seeking, and that maladaptive help seeking often leads to not just neutral outcomes, but worse outcomes. But they need not be a deterrent to becoming involved with patients. What they require is a level of self-reflection and self-monitoring that allows the clinician to, in the first place, do no harm. One of the things to keep track of is your own thoughts or feelings, which can be used as a reminder to reflect on what's actually happening in the therapeutic relationship, in the prescribing relationship. Often prescribers feel pulled or pushed to respond in particular ways, and they often feel frustrated that the patient won't do what they need to when it seems clear to the prescriber what the pathway to recovery is. But it's important to remember who's actually responsible for this change. The clinician doesn't bear sole responsibility for this, and how we engage the young person in responsibility for recovery is an important process which is supported by shared decision making, but then needs to be additionally supported by self-reflection about whether you're responding as you usually do or whether you're doing things differently. Are you being pushed or pulled into practice that's unusual? This is usually a guide to when prescribing is going on. Because some patients will invite clinicians to behave very differently to their usual practice, and we can be aware of these invitations without automatically feeling cheated or manipulated, terms that are often applied to this sort of patient, which then results in us becoming more rigid and inflexible and often refusing to do or being reluctant to do things that might actually be quite helpful for an individual patient. So some of the strategies that might help to manage these situations is to encourage patients to develop a sense of self-control, to help them to connect their feelings to the actual events and actions, to be more active and responsive and validating in your approach. That is to acknowledge their point of view, to try to put yourself in their shoes. And importantly, to engage in collaborative goal setting and experimentation, which is fundamental to all successful prescribing, but particularly important to successful prescribing in this patient group. And this involves being clear about what it is that the young person is seeking, agreeing to a shared set of goals, and then frequent review of these goals, which will assist the patient to persist either with the chosen strategy or to change that strategy in a collaborative way without becoming too rigid or inflexible, without the patient digging their heels in and saying, I must continue on this medication even if it's ineffective, or the clinician either insisting on prescribing or refusing to prescribe and getting into standoff with the patient. We also need to think about the meaning of our actions. Polypharmacy, that is, multiple prescriptions in an unplanned way, can often be experienced as controlling, punitive, or silencing, or repetitive. People just prescribe in order to get the person out of their office, or they might prescribe in a custodial or out-of-home care setting because people might be feeling angry or out of control and be insisting that something be done. But it's important that patients' needs and wishes are not ignored, because otherwise they'll experience this as withholding or depriving and denying, and often become reactive to that being ignored, which leads to a vicious circle of increasing demands and increasing refusal to go along with those demands. So relational prescribing is important in young people particularly because absence of evidence is not evidence of ineffectiveness. That is, we often are working in an evidence-free zone with young people. So we need to balance our needs with the needs of the young person. Often the young person is very distressed, wanting some relief from their problem, but we often dig our heels in saying, well, that drug doesn't have an indication on the PBS, or that drug doesn't appear in the guidelines. One way around this is the process of collaborative experimentation, which needs to respect the needs of the doctor and the limits of the doctor, but at the same time might well provide sedation or relief from distress or achieve the appearance that both parties are wanting. That is, that a clear goal-setting exercise, shared decision-making, and then a review of those goals might help to achieve a situation where the person feels listened to and understood, and where there can be a common sense discussion about the outcome, whether the medication is actually effective or not. One of the key points of reflection is actually to stop and think ourselves whether we actually have the right sort of skills to deal with the problem and whether we have the wisdom to say to the young person in front of us, I don't have the tools for the job at hand, or that medication is not an appropriate response to the problem that we are facing. And we need to be aware of our own limits and be willing to communicate these to the patients. We shouldn't be dressing up our own needs as if they are somehow the patient's needs, such as your own responsibility to prescribe safely, legally and ethically, which might be at odds with the patient's demands for immediate relief from distressing symptoms. So they might want benzodiazepines or some other restrictive medication, or a particular medication that only has an authority indication, and might be pressuring you to prescribe that. It's important to let them know that it's actually your needs that are also coming into play here, and that you have your own limits without being rigid and defensive in the way that we explain them. And we need to admit and be willing to openly discuss difficulties. It's much easier to start prescribing a medication than to stop it. So once you've opened the floodgates, it's very difficult to change the course that you've embarked upon. But an honest and open discussion about whether a trial of a drug is warranted or has been effective is fundamental to effective prescribing in young people. So I've gone through all the material that I hope to cover today, and I hope that it hasn't been too quick in order to keep to the time. But what I'd now like to do is move to a poll question before getting to some of your questions that we have on the screen. So what I'd like you to do is have a look at the poll question on the screen, which says, how confident do you now feel when prescribing medication for youth? And to re-rate your response to see whether there's any change in your level of confidence. Okay, so we'll move on from the poll question. There are a couple of questions that I'd like to get to from the screen. One of them is someone who's asked, are there any guidelines about changing psychotropic medications and dosages throughout a young person's treatment? There are guidelines for individual disorders, such as the National Early Psychosis Guidelines, which do talk about changing medication. The youth depression guidelines, the NHMRC guidelines, are a little more vague. Unfortunately, they really say fluoxetine first, and then they don't really give much advice on what to do after that. And this is the problem, that they can only really give advice about changing treatments where there is evidence to support this, and the early psychosis guidelines are the best example of that. Other guidelines for adult disorders are much more comprehensive in their ability to guide the changing of medications, and often in the absence of evidence in young people, we do turn to those guidelines for some advice. There's another question about why is quetiapine potentially abused. This is something that often is not known in the outside the drug taking community, that quetiapine is often used to manage the effects of other medications, often to manage the withdrawal or discontinuation of amphetamines and other drugs that lead to agitation in the withdrawal phase, but also is sometimes a drug of abuse in its own right, and has a street value and is on-sold on the street. So that's all we have time for, because we've come to the end of the original allotted time period. So I'm going to hand you back to Shona, but I'd like to thank you all for attending today, and I would be happy to field any questions by email or any further inquiries. So thank you, and I'll